Okay, tibialis anterior, originating on the lateral condyle body of the tibia, as well as the interosseous membrane, inserting onto the base of the first metatarsal. It acts to dorsiflex and invert the ankle, and you can see that tendon pop up right here strongly. A manual muscle test for tibant is resisted dorsiflexion and inversion. So if you bring them up into this position and try to pull them into plantar flexion and eversion, because it can be a bit of a tricky movement to cue the person on. So I'm going to try to move you, don't let me. 5, 4, 3, 2, 1, and relax. A length test to compare bilateral for shortness. If you bring the ankles, grasp each of them at the same time into plantar flexion and eversion, it can give you a sense if one side is longer than the other. But if tibialis anterior is really shortened, most or all ranges of the ankle will be restricted usually. Common trigger point location, about 1/3 of the way into the belly of the muscle, and it will refer strongly over the anterior medial ankle and into the big toe, usually skipping the forefoot here, but not always, so they can get pain just at the ankle and just to the toe, just in the toe, or a combination of all three. For attachment release, we're going to perform our frictions up here around the lateral epicondyle. Keeping in mind those neurovascular structures around the head of the fibula. So our longitudinal frictions in this direction, superior to inferior. And then typically our cross fiber frictions, I pull from lateral to medial, just to avoid those neurovascular structures around the head of the fibula. The insertion, I'm going to show you on this foot just so you can see. So it's coming into kind of the side of the first metatarsal and the first cuneiform. This will be a really tender little area on people, but you can friction directly on it. So if the tendon is coming in this direction here, my longitudinal frictions, I'm going to perform just with one finger, reinforced longitudinally and cross fiber. To reset tibant, we're just going to bring into that dorsiflexion and inversion. You can do them as a combined motion. And just asking your patient to bring their toes up towards their knees. And then all the way down 3 times. 1, 2, 3. Good. To stretch tibialis anterior, some sources say that it's an unstretchable muscle just based on where the attachments are. But if you wanted to try, you bring them into plantar flexion and eversion. But usually they don't. If they feel any stretch, it's over the top of the ankle. You can try stabilizing here around the condyle, get more of a fascial pull. But people will very rarely feel a strong stretch right in the belly of tibialis anterior. To do a contraction, I would say gently push your foot up into my hand. 5, 4, 3, 2, 1, and relax. And then increasing. Approximation, the position would be dorsiflexion, but let me do it. Just relaxed here, sorry. So passive dorsiflexion and inversion. And this is one that if you're feeling like that tone of the muscle isn't reducing, you add a gentle linear compression through the ankle Sometimes that helps that muscle let go. Some people are really sensitive in through here, some people aren't. You can use an ulnar border of the elbow, especially if you're trying to treat fascially. You can use knuckles, or even like your olecranon sinking in this way. Some warm-ups I like to do are shearing off of the tibia, stabilizing with the top hand, shearing down towards the table. Just working my way all the way through. And not forgetting its insertion point on the foot. And people will have this nice, crunchy, tender little spot right where it inserts. Some home care you can give people, especially if they're sitting at the desk all day. You can do this seated or laying down. Instruct them to do like an ankle alphabet. So like, can you spell an A with your foot? A, and then B, and C, and so on and so forth. Keeping the ankle moving frequently throughout the day if they have a sedentary job.